some information about the clinical cases from your exam 2 days ago, okay? Because maybe you have any question to ask. So this is the first clinical case that you had. This was a 60-year-old male that goes to the hospital with fever, cough, and weight loss. A sputum sample is taken from and sent to the laboratory. And nothing is seen in the gram stain, and they find acid-fast positive rods in the Sill-Nielsen stain. The culture, nothing, because it requires several weeks. So, question number 1. Bacteria, genus and species, the most common that cause this disease. Can you tell me?
Tuberculosis? No.
Mycobacterium tuberculosis.
Yes.
The genus is Mycobacterium. The species is tuberculosis, and you have to answer both words, okay? Genus and the species. Genus Mycobacterium, species tuberculosis. Question number 2. Nothing is found in the gram stain. Why? Why not?
It's very hard to stain.
Why?
It has the high content lipid on the outer layer.
Because it has many lipids, yes. That is the reason. Mostly glycolic acids. But if you answer because it has many lipids, it's enough. Okay. How is the disease transmitted? Mechanism of transmission? Through the air, airborne transmission. Question number 4. What is the best antimicrobial treatment for this patient? This is one of the few antimicrobial treatments that you must remember. Antimicrobial treatment? Sorry, I cannot wait. So 8 weeks, isoniazid, rifampin, pyrazinamide, and ethambutol. And later, 18 weeks, isoniazid and rifampin. That is the most common combination of antimicrobials to the treatment of tuberculosis, okay? This is one of the antimicrobials, this is one of the antimicrobial treatments that you must remember. Okay, clinical case number 2. This is a 3-year-old boy, so a child, with these lesions in the skin, okay? So we give you a picture of the lesion and a picture of the gram staining. What's the name of this lesion? Sorry?
Impetigo?
Impetigo. This is an impetigo. This is a typical impetigo. Child lesions around the skin, around the lips and around the nose. Epidermal infection. This is an impetigo, yes. Question number 2. According to the gram stain, what is the name of the bacteria? Genus and species.
Streptococcus pyogenes.
Streptococcus pyogenes. Yes. The genus is Streptococcus. Species pyogenes. That is the most common, yes. According to the gram stain, because you already know that Staphylococcus aureus can also cause impetigo, okay? But this gram is not Staphylococcus. This gram is Streptococcus pyogenes. Yes. And the last one is very easy. Diarrhea. Woman, young woman with fever and diarrhea, with good condition. Stool sample is taken and sent to the laboratory. Gram-negative rods grow in the stool. A picture is attacked. What bacteria is this? Only the genus?
Campylobacter.
This is a Campylobacter, yes. The typical appearance, gram-negative rods with spiral shape, Campylobacter, okay? Possibly Campylobacter jejuni, but we only ask you the genus, Campylobacter. How is this bacteria transmitted?
Foodborne.
Foodborne disease, anything else?
Poultry.
From the poultry, so from the food. And which food? The poultry, yes. Usually chicken, yes. Through the fecal oral route, foodborne transmission. What kind of food? Usually poultry. That is the correct answer. Okay, so do you have any question about the clinical cases before we start the class?
No.
Questions? Oh, of the clinical case.
Các bạn có câu hỏi gì về mấy ca lâm sàng này không các bạn? Maybe no. No.
No question? Okay. So we are going to start the class. So we are here. So we start the class. Wait a moment. Wait a moment, sorry. Okay, so this is the table of viruses that we study. So we are going to continue now with the study of Flaviviridae. And we are going to study yellow fever. Yellow fever belongs to the family Flaviviridae. I remind you that flavi comes from the Latin language, yellow, because yellow fever belongs to this family. Okay. Wait a moment. Okay, so we are here. So we start with the study of yellow fever. Yellow fever is a hemorrhagic fever, as I told you in the last class, with very high morbidity and mortality, as I will tell you later. This is another arboviral disease. So the pathogenesis is very similar to the pathogenesis that I showed you for dengue yesterday. The vector is Aedes aegypti, the same vector as for dengue. Yellow fever is found mostly in sub-Saharan Africa and in South America. Yellow fever is not found in Asia. Look, the vector is the same as dengue, Aedes aegypti. However, we don't have yellow fever in Asia, and we don't know why. We have a vaccine. Currently, vaccination is the most important preventive measure. So, not in Asia, and we don't know why. We have no idea. Only sub-Saharan Africa and South America. This is what happens, okay? The transmission of yellow fever, very similar to the transmission of dengue. This is South America, this is Africa, but it's almost the same. In the forest, the disease is transmitted from animal to animal through the mosquito. Sometimes, the mosquito can transmit the disease to humans, and humans can transmit the disease to other humans, because for yellow fever, humans are natural hosts, as I told you yesterday. In Africa, it's almost the same. So from monkeys to monkeys in the forest, transmitted through mosquitoes. Sometimes the mosquito can transmit the disease to the human. And in the cities, humans can transmit the disease to other humans through the same vector. So this is the same as we studied yesterday for dengue. Look, in this picture, I show you here dengue and yellow fever, both. Dengue in orange color. We have a lot of dengue in Asia. With red strips, I show you yellow fever. So sub-Saharan Africa and South America, but not in Asia, and we don't know why. So what about the immune response against yellow fever? What about the immune response? It's very complex, very difficult to understand. I have to tell you that, well, yellow fever is another flavivirus, and maybe some immunity against other flavivirus can protect people against yellow fever. I explain. Flaviviruses are so many. Dengue virus, yellow fever, Japanese encephalitis, West Nile, Zika virus, a lot. And maybe antibodies can cross-react against different flaviviruses. For example, if we are infected with dengue, we will develop antibodies against dengue. And maybe these antibodies against dengue can protect against yellow fever a little bit. So maybe this is one of the reasons why we don't suffer yellow fever in Asia, but we are not very sure. So cross reaction between all flaviviruses. When we suffer yellow fever, after recovery, the protection is forever, lifelong. The outcomes of yellow fever, the most common outcome are asymptomatic infection and non-specific infection disease. So the same as for dengue, the same as for all arboviral diseases. The most common outcomes, asymptomatic or non-specific infection. However, in some people, very few, about 15% of people will suffer a severe disease, as I will tell you later. This is not microbiology, this is clinical medicine, but I have to explain you a little bit, okay, about clinical medicine. The clinical findings of yellow fever can be divided into 3 periods, 3 stages, 1, 2, and 3. Infection, remission, and intoxication. This is the worst one, the most severe. In patients with infection, the first period, this patient will show non-specific findings, non-specific symptoms that you already know: fever, headache, myalgia, arthralgia. So these symptoms are non-specific. We say that they are non-specific because we can find them in many different diseases. That's the meaning of non-specific. Non-specific symptoms. So during this period, the virus is replicating a lot. So viremia, a lot of replication. And this period lasts for 3 to 4 days. What happens after that? For most people, around 85% of people, they improve very much. And these symptoms disappear. So most people recover. This is the most common outcome: improvement, recovery. The most common outcome, 85% of patients. However, in 18% of patients, they will become very severe, very severe. This is the period of intoxication. So in these patients, the non-specific symptoms return again. So fever, headache, myalgia, arthralgia, whatever. In these patients, new symptoms appear. The severe symptoms, the complications. The complications of yellow fever appear in the liver. So patients appear yellow, jaundice. This is the reason why we call this disease yellow fever. In the kidney, these patients show renal failure. Coagulation, because the damage of endothelial cells. So problems in the coagulation. So these patients have a higher risk of bleeding. And finally, shock, that I am not going to explain because this is clinical medicine and you will study next year, and I don't have time. Okay, so patients, these are the complications of yellow fever. This is the period of intoxications. Very few patients, 15% of patients. This period of intoxication, the most severe, appears 3 to 6 days after the onset of symptoms. 50% of these patients will die. 50% of patients will die, these patients. During the period of intoxication, the virus is not replicating. There is no viremia. During this period, antibodies appear. So maybe all of this damage is not related with the virus. Maybe this damage is related with the immune response. During the period of remission, the virus stops replicating, so viremia decreases. Most patients stay here. So this is a picture of yellow fever. This is clinical medicine, this is not microbiology. And this is not very important for you because we don't have yellow fever in Vietnam, okay? But I have to explain you a little. So we go back to the presentation. How can we make the diagnosis of yellow fever? The diagnosis at the laboratory of microbiology is very similar to the diagnosis of dengue. So we can detect antibodies, serology. However, antibodies appear late. So, like dengue, the detection of antibodies is better after the day 5 of the disease. So the same as dengue. The detection of antibodies is the most common method for diagnosis. We detect IgM that appears earlier, and we detect IgG that appears later. So detection of antibodies after day 5. We can also detect the virus. We can detect the nucleic acid by PCR, but this is possible better before the day 5, because later the virus is not replicating, so we don't find the virus in the blood. So the diagnosis of yellow fever is very similar to the diagnosis of dengue. Detection of antibodies, better after the day 5. Detection of the nucleic acid by PCR, better before the day 5. We don't have any specific antiviral therapy. The treatment is only supportive, symptomatic. Like dengue, aspirin and other non-steroidal anti-inflammatory drugs should be avoided, because we know, you will study in biochemistry and you will study in pharmacology, that these drugs interfere with the function of platelets. So they are not allowed for patients with dengue and for patients with yellow fever. We have a vaccine, and this vaccine is very good. This vaccine is live attenuated. So remember, live attenuated vaccines should not be given to immunocompromised people or to pregnant women. We explain you this in the self-learning topic 5. The vaccine against yellow fever is very old. It appeared 80 years ago. It's very effective. And currently, we only use one dose, a single subcutaneous dose. So it's very easy to administer. Some years ago, the vaccine was given 2 times with booster doses. But currently, we know that only one dose is enough. So currently, the World Health Organization recommends the vaccination for all the people that are living in endemic areas of South Africa and South America. All people, also for travelers. So, if you want to travel to these places of Africa and South America, you need to vaccinate yourself. If not, you cannot enter in these countries and you cannot come back to Vietnam. So this vaccine is recommended for endemic areas. Any question about yellow fever? Any question? Oi, do you want to say something about yellow fever? Yes, please.
Các bạn có câu hỏi gì về virus gây sốt vàng không ạ? Cái con virus này nó không phổ biến ở Việt Nam mình, nó không, hầu như là nó không có. Có một cái điểm mà thầy giải thích cho các bạn đó là đối với những cái virus mà thuộc họ Flaviridae, khi mà nó xâm nhiễm vào cơ thể chúng ta thì nó sẽ sinh ra kháng thể, và hầu như là cái kháng thể đó nó có thể giúp cho chúng ta có thể chống lại được với virus sốt vàng. Cho nên là vì Việt Nam chúng ta cái tỷ lệ nhiễm đối với virus dengue nó cao, nên cái kháng thể đó nó có thể tồn tại và giúp cho ở người châu Á chúng ta có thể kháng được với cái virus này.
Okay, so look, so we have studied 2 flaviviruses very similar, yellow fever and dengue virus. The most important for you to remember is dengue virus, because we don't find yellow fever in Vietnam. Okay, so we are going to continue with the study of encephalitis. Encephalitis is the plural of encephalitis. So this is an infection of the central nervous system. This is an important problem in Vietnam. In Vietnam, these diseases are very common, mostly in children. You will see later. If we have time at the end of the class, I will tell you something about encephalitis in Vietnam. Many viruses cause encephalitis, many different. A lot. We are going to study only some. So look, so we are here. We are going to study the viral encephalitis. We can classify these diseases into two groups: zoonotic, so transmitted from animals, or non-zoonotic, not transmitted from animals. Non-zoonotic, the most important in the world, and also in Vietnam, is herpes simplex virus type 1. So remember, this is human herpes virus type 1. Encephalitis. This is the most important, the most common. What about zoonotic viruses that cause encephalitis? We have two groups: transmitted by arthropods, arboviruses, and not transmitted by arthropods, non-arboviruses. What about arboviruses? The most important in Vietnam is Japanese encephalitis virus that we are going to study now. This is the most important in Vietnam. This virus is also a flavivirus, transmitted by mosquitoes. Another one that you have in the handbook, but maybe we don't study, is the West Nile virus. This is also found here, but not very common. West Nile virus. This is another flavivirus. And we have others, we have a lot. What about non-arboviruses? What about non-arboviruses? We are going to study one, the most important, rabies. Rabies virus, transmitted from animals, but not through arthropods. And many others, we have a lot. Here in this group of non-zoonotic, we have a lot, so many. For example, enteroviruses, and many others, okay? But we are going to mention only one. So now we are going to study Japanese encephalitis virus because it's the most common in Vietnam. So we are here. The Japanese encephalitis virus is not only found in Japan, it's found in many countries in Asia. In Vietnam, the same. Japanese encephalitis is the most important cause of epidemic outbreaks of encephalitis in the world, also in Vietnam. To study Japanese encephalitis, we are going to use a table because you know already that I like the tables very much. And this is easier for you to understand. So we are going to study Japanese encephalitis. Later, if we have time, we will say some words about the West Nile virus. Japanese encephalitis virus belongs to the family Flaviviridae. Family Flaviviridae. The natural host is an animal. Natural hosts are birds. Birds that live in the water. So we can say that they are aquatic birds. Some birds. I don't know exactly the species. I know that they are birds that they live near the water. The dead end host, so the final host that cannot transmit the disease, are humans. So humans suffer the disease, but we don't transmit the disease to others. And the vector, mosquitoes. Mosquitoes that belong to the genus Culex, that you will study next year in the practice of parasitology. However, in the middle, we have another host that we didn't explain yesterday, that we call amplifying host. And what is this? What is an amplifying host? This is the epidemiology of Japanese encephalitis. So look, natural host, the birds. The transmission of the disease from bird to bird through the Culex mosquito. Okay, this is what usually happens. However, during the rainy season, the number of mosquitoes increases a lot, as you already know. So what happens? When the number of mosquitoes increases, mosquitoes start feeding in different hosts that are not natural hosts. Mosquitoes start on feeding in different animals, many different animals. The most common, the pig. And these animals, the pigs, live very closely with humans. The pigs are not natural hosts. They don't suffer the disease. However, they develop a lot of viremia, so they can transmit the disease to other hosts. Because these animals are living very near to the humans, they are peridomestic animals, mosquitoes can transmit the disease to humans. So humans are exposed to mosquitoes infected from pigs, not from the birds. From the birds, it's very unusual because the birds live in the forest. So humans become infected because the mosquito feed in the pigs. This is the amplifying host, the pig. And this only happens when the number of mosquitoes is very high. This only happens during the rainy season when the number of mosquitoes is very high. So in the middle, between the animal, the bird, the natural host, and the dead end host, the human, we have another host, the amplifying host. Many different animals. Peridomestic animals. So animals that live around the house. That's the meaning of peridomestic. The most important, the pigs. So the transmission of the disease to the humans comes from the pigs. What about the clinical findings? The clinical findings are the same as for other arboviruses. The most common outcomes are asymptomatic, the same as for all, or non-specific findings. So non-specific, fever, headache, myalgia, arthralgia, the same non-specific symptoms that we always say. These are the most common outcomes. However, in less than 1% of people, they will suffer severe disease, severe central nervous system disease, so encephalitis. Less than 1%, so not many. And what happens in these patients? These patients will suffer a severe disease. Some patients will die. If not, between 30 to 50% of patients will have sequelae when the disease finishes. This is the problem. How can we make the diagnosis? The diagnosis of Japanese encephalitis virus is made mainly by the detection of antibodies, so by serology. The detection of antibodies, mostly IgM. IgM is the first antibody that appears. We can detect IgM in the cerebrospinal fluid, in the CSF. If we detect the IgM in the cerebrospinal fluid, we can confirm the disease. So this is the confirmation of the disease. We find IgM into CSF, confirmation of the disease. However, we can also detect IgM in serum, in blood. However, when we detect IgM in serum, we are not very sure that the patient is suffering encephalitis because of Japanese encephalitis. In serum, we can say only that the patient is possibly infected. Why? Because IgM also appears in vaccinated people. IgM also appears in asymptomatic people. So if you have a patient with encephalitis at the hospital and we detect IgM in serum, maybe the patient is infected by another virus, not by Japanese encephalitis virus. So the confirmation of the disease is by the detection of IgM in CSF, not in serum. And what about PCR in serum? PCR is not very useful. Why not? PCR in serum is not very useful. Why not? Question for you. Why PCR in serum is not very useful? So the detection of the virus in serum. What?
Because virus cannot survive in high temperature.
No. The virus can survive with high temperature. No. Why not? Why the PCR in serum is not useful? We can do it, but the sensitivity is very low. Why not? Why not? Because humans are dead-end hosts. That means viremia in humans is very, very low. If viremia, so viruses in blood, is very low, the detection of the virus in the blood is very difficult because viremia is very low. So PCR in serum is not useful because viremia is low. That is the answer. We have a vaccine against Japanese encephalitis. Actually, we have two vaccines. We have inactivated vaccines, very expensive, and we have live attenuated vaccines, both. In Vietnam, we think that you are vaccinated already against Japanese encephalitis. So we go back to the presentation. This is the Culex mosquito that we have here. Next year, when you study Kisinchung, the practices of parasitology are very good here because the laboratory of parasitology is very good. And you are going to learn to differentiate mosquitoes very well. They culture mosquitoes in the laboratory. They have many cultures. They have larvae, they have pupa. You will learn a lot in parasitology next year about mosquitoes. And maybe you have to collect mosquitoes at home and you will identify the mosquitoes. Culex mosquitoes, the transmission of Japanese encephalitis from the pigs to humans. Where can we find Japanese encephalitis? The risk is very high in rural, agricultural areas of Asia. So where? In two different areas. We can find Japanese encephalitis in tropical weather. Cambodia, Indonesia, the south of Vietnam, the south of Thailand. In these places, Japanese encephalitis is found year-round. So always, from January to December, always, but more cases during the rainy season because the number of mosquitoes increases. Japanese encephalitis is also found in temperate climates, in China, in Japan obviously, yes, in South Korea, Nepal, in the north of Vietnam, and in the north of India. In these places, we find Japanese encephalitis during several months, mostly when the weather is warmest. Also related with heavy rainfall, so when the number of mosquitoes increases. What about Vietnam? Japanese encephalitis is found everywhere. Japanese encephalitis is endemic or hyper-endemic in all provinces of Vietnam. Mostly in the north from May to October, so when the weather is warmest. What about in the south? Always, because the south is always hot. Most cases of Japanese encephalitis are found in Hanoi and near Hanoi, but we have everywhere. These are the countries in Asia where we find Japanese encephalitis virus. In endemic areas, so in Vietnam, Japanese encephalitis typically affects children, young children, because they are infected very early in life. When we are infected, immunity is forever, so we will be protected forever. I told you that very few humans, less than 1% of infected people, will be symptomatic, but they will be very severe with a very high mortality. And if they don't die, they may have sequelae between 20 to 50 to 30%, as I told you. We don't have any specific antiviral treatment. So the treatment is only symptomatic and supportive. And we have a vaccine. We have different vaccines. Maybe this one is the most common, Ixiaro. This is the most expensive. We have different vaccines in Asia. We have one also manufactured by a Vietnamese company, this one. So I think that all of you have been vaccinated, right?
Yes.
Okay. So do you have any question about Japanese encephalitis virus before we continue?
Yes. Why they named that Japanese encephalitis? It is
Why is
first
the name
time.
Japanese? I suppose because it was discovered in Japan, but I don't know exactly. I suppose because the first cases and the isolation of the virus was made in Japan. But I don't know.
Okay,
More
thank you.
But I don't know. I suppose that I have no idea. More questions? No? Okay, so in 1 minute, because we have 1 minute, we are going to say something about the West Nile. The West Nile virus is not explained in the presentation. It's explained in your book, but not in the presentation. So, but we are going to say very few words, okay? The West Nile virus is not very common in Vietnam, but it's common in other places. The West Nile virus is also a flavivirus. So the pathogenesis is very similar. The West Nile virus, the natural host, is also a bird. Some birds from different species. And humans are also dead end hosts. So we suffer the disease, but we can't transmit the disease. We don't have any amplifying host in the middle, to my knowledge. The transmission, the vector of transmission are also mosquitoes. Many genera of mosquitoes. But maybe the most common are also culex, maybe the most common. But Aedes may be also vectors of West Nile encephalitis. What are the outcomes? The outcomes are the same as for Japanese encephalitis. Most patients will be asymptomatic, most patients, or non-specific disease. And less than 1% of patients will suffer encephalitis, so the same. And some of them with sequelae. And the diagnosis is also by serology, by the detection of IgM. So the diagnosis is very similar to Japanese encephalitis virus. However, for West Nile, we don't have any vaccine, okay? So we only say this about West Nile virus because this is not so common. So the one that you must remember is Japanese encephalitis, okay? So we are going to continue with the last one, with another encephalitis, also zoonotic, but not arboviral. We are going to study the rabies virus. That is very important in Vietnam, unfortunately. So rabies virus belongs to the family Rhabdoviridae. The family Rhabdoviridae is a new family for you. Rabies is a Latin word that means madness. So you can imagine what happens with rabies. And the family Rhabdoviridae contains many different viruses, but the most important is the rabies virus, and this is the only one we are going to study. This is the structure of the virion of rabies. The shape is very strange, as you can see. It's like a bullet. The nucleic acid is negative single-stranded RNA surrounded by a helical capsid. And this is the envelope. The envelope is very strange, as you can see. It's not spherical. It's like a bullet. The envelope contains glycoproteins, and some of them, this one, the G1, binds host cell receptors. This is the shape of the envelope, very strange. By the way, you don't have to remember, when we study viruses, you don't have to remember if they are positive or negative. This is not important for you. This is important for me, but not for you. You have to remember if the viruses are RNA or DNA, but you don't have to remember if they are positive or negative, okay? That's not important for you. So this is the family Rhabdoviridae with many viruses. We are going to focus only in one. We are going to focus in the rabies virus. What is rabies? Rabies is a zoonotic, acute, viral encephalitis. This is one of the oldest and most feared human infections. Rabies is the infectious disease with the highest mortality that we know. All patients will die, 100%. All of them, no survivors. Very few people have survived to rabies. Just 5 or 10, I don't remember, but very, very few. So the general rule is that all people will die. No people survive, very, very few. Rabies was firstly recognized more than 3,000 years ago. Rabies affects all mammals, all. So all mammals have risk to suffer rabies. Rabies is found everywhere in the world, all over the world, with very few exceptions. Very few countries have removed rabies, very few. Currently, the World Health Organization estimates that around 60,000 people die every year because of rabies, mostly in Asia and Africa. The highest incidence of rabies is found in Southeast Asia, also in Vietnam. This is an important problem in Vietnam, in the Philippines and India. And why is this possible? Because the dogs. Because there are many dogs living in the street, we say stray dogs, and they are not vaccinated against rabies. So the problem here, the problem in Vietnam, is the control of dogs. This is the problem. The first vaccine against rabies was developed more than 100 years ago by Louis Pasteur. This was one of the greatest achievements in microbiology. The transmission of rabies virus is through inoculation. Inoculation into the skin. Exposure to saliva from an animal bite, mostly dogs. 99% of patients with rabies have been infected from infected dogs. In very rare cases, rabies results from a different exposure through inhalation, but that is very, very uncommon. Later, I will tell you another case, but that's very uncommon. And before you ask me, because every year students ask the same question, human to human transmission is possible. If an infected human bites another human, the transmission of rabies is possible. So this may occur. However, we don't have any case reported, okay? So the transmission from human to human is possible if the human bites another human. But currently, I haven't found any case. So cases have not been reported. In orange color, I show you the countries with the highest risk of rabies in the world. Also Vietnam. We can find many cases in Vietnam every year. This is the problem in Vietnam. This information about Vietnam have been found in these papers that you can find for free. These papers have been written by Vietnamese medical doctors, okay? So the problem in Vietnam appears mostly in the north and in the highlands, mainly in the Hatay province and the Phu Tho provinces. Why? Because in Vietnam, most dogs are not vaccinated. The Vietnamese scientists from this paper, they say that the problem in Vietnam is that people commonly raise stray dogs. And these dogs are usually not vaccinated. Just only 10 to 20% of dogs are vaccinated. And this is very few. Vietnamese doctors also consider that dog butchering or eating is also a risk factor for the transmission of rabies. And this problem happens mostly in the north. So the problem here are the dogs, 99% of human cases. But rabies is also found in other animals like bats, raccoons, skunks, foxes, monkeys, rats, many different animals may transmit rabies. The pathogenesis of rabies is very complicated. I am going to try to explain firstly in the whiteboard and later with a picture. So we go here. So we are going to explain the infectious cycle from exposure to disease. Exposure is through inoculation. To the bite, okay? Usually a dog bite, 99% of times from dogs. So what happens after exposure? After exposure, the virus infects muscle cells. So there's a local infection. So local means near the wound. Local infection of muscle cells. So the virus can enter inside the muscle cells and replicate inside the muscle cells. And this is very important. So the number of virions increase. And now comes the most important step in the pathogenesis of rabies. Viruses, so the virions, enter inside the local peripheral nerves. These nerves are both sensitive and motor nerves, both. You know this from anatomy. When the virus enters inside the local nerves, the disease cannot stop. The patient will suffer rabies and the patient will die. So this step is the most important. The entrance of the virus inside the local nerves. If we want to prevent the disease, we have to prevent the disease before the virus enters inside the nerve. This is the most important. What happens later? When the virus enters in the nerves, the virus travels, moves, migrates. So this is a migration of the virus to the spinal cord. Very slowly. The virus moves around 5 to 10 centimeters every day. So very slowly. So finally, the virus reach the dorsal ganglia of the spinal cord. And they replicate here again in the dorsal ganglia. They arrive later to the spinal cord. When they arrive to the spinal cord, they can move upwards, so they can ascend to the brain. And they will infect the brain, encephalitis. And after that, viruses can move again from the brain in the opposite direction. So they can descend from the brain to other tissues. So they can move through other nerves. So traveling through somatic and autonomic nerves that you already know from anatomy. And they can infect many different tissues. They will go mostly to the highly innervated tissues. For example, the salivary glands. So a lot of virions will be released in saliva. This is the reason why the disease is transmitted through the contact with saliva. So this is the infectious process from exposure to disease. And now I show you the picture. Well, before that, this is from Netter, Atlas of Anatomy, the best one, to show you that these and these are the dorsal ganglia, close to the spinal cord, okay? So look, this is what happens. First step, bites you. Exposure. This is the first step, okay? So the virus is inoculated onto the skin. The virus infects the muscle cells, and the virus replicates in the muscle cells in the beginning. So viral replication in the muscles. Later, the most important step, this is the most important. After replication in the muscle, the virions, viruses, enter in the local peripheral nerves, and they will travel through the nerves until they reach the dorsal ganglia, close to the spinal cords. This, the dorsal ganglia. They replicate here. Later, they will reach the spinal cord, and they will migrate to the brain through the spinal cord. So they go to the top, to the brain. And they will infect the spinal cord, the brainstem, the cerebellum, the brain. So the virus replicates in the neurons. So look, rabies virus can replicate mostly in the neurons, but also in the muscle cells close to the wound. So the virus replicates in the brain, in the neurons, and later the virus moves in the opposite direction, following the motor and somatic nerves. Sorry, the somatic and the autonomic nerves. To the lacrimal glands, to the salivary glands, to the skin. So the virus in the beginning moves to the brain, and later the virus moves in the opposite direction, following somatic and autonomic nerves. This is the pathogenesis of rabies. So, as I told you before, the virus is found at the end in highly innervated areas, mostly the salivary glands. So there is a high concentration of the virus in saliva. Again, the most important step in the pathogenesis of rabies is when the virus enters in the local peripheral nerves. So once the virus has entered in the nerves, the disease cannot stop. So the post-exposure prophylaxis should be given before the virus enters in the local peripheral nerves. So look, the risk to develop rabies is not the same if the dog bites you on the leg or if the dog bites you on the face. Or the risk also depends on the amount of saliva. So for example, on the skin of the face and the head is more likely to result on disease, and because you don't wear clothes. However, in the leg, because you wear clothes, the amount of saliva in the wound would be lower. So the disease depends on many factors. The incubation period also depends on many factors. The incubation periods range from 20 to 90 days. So if the dog bites you in the foot, the incubation period will be very long because the virus has to travel from the foot to the brain. However, if the dog bites you in the face, the incubation period will be very short because the distance from the face to the brain is very short. However, once the patient shows clinical signs of disease, the patient will die. All, with very few exceptions, very, very few. So the most common outcome is death. So what is rabies? Rabies, this is not microbiology, this is clinical medicine, but I have to tell you something. You will study next year in internal medicine that rabies has different stages. We are going to focus in acute rabies. Acute rabies may be found into two different forms. Encephalitic rabies, this is the furious rabies, and paralytic rabies. This is not common, only 20%. So here we are going to show you only the findings of encephalitic furious rabies, 80% of cases. What happens after that? Very few days later, patients will have a very low level of consciousness, that's called coma, and they will die later. In the link, you have a very good video. The video is very old, but it's very good to show you what hydrophobia is. That video is from an Indian patient and was recorded 60, 70 years ago, but it's enough to understand that. We are going to show you now another video that you will never forget about what hydrophobia is. So look, acute rabies is found mostly as encephalitic furious rabies. Furious means aggressive, okay? 80% of cases. Patients with encephalitic rabies, the most typical finding, the most characteristic finding is hydrophobia. What is hydrophobia? Hydrophobia means fear to water. Hydro in Greek language means water. Phobia means fear. So what is this? This is found in many patients with rabies, between 33 to 50 patients with rabies. Hydrophobia is a contraction of the muscles of the pharynx, involuntary, when the patient wants to drink. So the patient can't drink. It's like a fear of water, like a terror of water. That is hydrophobia, and this is terrible. This finding is terrible. I will show you the video now, and I show this video every year, and after I show this video to the students, they never forget. They will always remember, because this video is a Vietnamese patient. This video was recorded 12 years ago in Bệnh viện Bệnh nhiệt đới in Hanoi, the Vietnamese patient with rabies. So I will try to show you now. Wait a moment. Wait a moment, because I have to find the video. Where is the video? Here. Okay, so I will try to show you the video if I can. Can you see it on the screen? Yes, you can. So this is a patient with rabies, Vietnamese from the north, from Hanoi. And this patient died 2 days later after recording this video. So look, this is hydrophobia. You cannot see the video?
No.
We can see videos.
Wait. Okay. So, well, I hope that we can see it. So look, Vietnamese patient from Hanoi with rabies, encephalitic rabies. So this is a male patient, 48 years old, construction worker with rabies. Could you see the video?
Yes.
This is the typical hydrophobia. And I am sure that you will never forget hydrophobia because it's a terrible finding, terrible. And well, they die. Nobody survives. Okay, so you will never forget this. I will tell you the story of this patient now. This patient, wait, sorry. We are here. Wait one moment. This is hydrophobia. This patient is a Vietnamese patient, and he found a dog in the street, and the dog was dead. So he didn't have any wound. The dog didn't bite the patient because the dog was dead. This patient took the dog to his house to prepare the dog for eating. So he opened the head of the dog to take the brain for eating the brain. Because I don't know, but I was reading in the paper, and it seems that eating the brain, well, some people believe it's wrong, but some people believe that eating the brain of the dog gives you any kind of power. I don't know exactly. This is what they explain in the paper. So this patient opened the head, he took the brain for eating, and it seems that this patient was infected by inhalation of viruses. This is very uncommon. This is very, very strange. So this patient was infected possibly through inhalation of viruses. You can find this clinical case because this clinical case is very, very interesting. This clinical case is this one. published 10 years ago by the Oxford University Clinical Research Unit in Hanoi. And this is free. You can find this paper for free. And if you read the story of this patient, you are going to learn a lot about rabies. I was very surprised. I was working with this person a long time ago, and he told me about the patient. And I was very surprised that rabies could be acquired through inhalation. That is very, very uncommon. Okay. So please, if you have time, you can find this paper and you are going to learn a lot about rabies in Vietnam. Anyway, hydrophobia. You will never forget, okay? This is the most typical finding of patients with encephalitic rabies. Aerophobia is also typical, but not common. Aerophobia means aero in Greek language means air. Phobia means fear. It's also found in 9% of patients. And aggressiveness or agitation is also found sometimes. How can we make the diagnosis of rabies? The diagnosis of rabies is clinical diagnosis, clinical. The microbiology laboratory can also help, but not very much. The diagnosis is clinical. So I can show you in the whiteboard what can we do at the laboratory of microbiology. So diagnosis of rabies. The diagnosis of rabies is made clinically. Symptoms and signs, mostly hydrophobia. The microbiological diagnosis is also possible, but maybe not very helpful because patients die. So what can we do at the laboratory of microbiology? We can detect antigens. Antigens of the virus. So we can detect viral antigens. Where? In biopsies. In biopsies, in two different biopsies. Traditionally, we can take a biopsy from the skin of the neck skin, because the neck skin is highly innervated here. Neck skin is highly innervated. So we take a biopsy and we can find antigens there in the neck because it's highly innervated. This is the traditional diagnosis, to take a biopsy from the neck. And we can take, this is what we do, sorry, this is what we do if the patient is alive. In alive human patients. We can also take a biopsy from the brain. But this is what we do if the patient is dead in the patient. And this is what we do in animals. To detect viral antigens. What can we do? We can detect the RNA. By PCR that you already know. The detection of the RNA is possible in the biopsies so in the biopsy of the neck or the biopsy of the brain, and detection of the RNA is also possible now in saliva, because the concentration of viruses in saliva is very high. So PCR. And what else? In some places, they can culture the virus, but this is very uncommon, very rarely. It's not usual. Or serology, the detection of antibodies. But this is not useful because antibodies appear very late. So currently, maybe the most common method for diagnosis is to take a biopsy from the neck for the detection of antigens and for PCR. This is the most common. Currently, we don't have any proven antiviral therapy against rabies. So most patients will die, 100%. However, when we read the books of microbiology and the books of internal medicine, we find something that it's called the Milwaukee Protocol. And what is this? About 15 years ago, a girl, I think 14, 15 years old, suffered rabies, and she was treated by a combination of drugs. She was treated with ribavirin, amantadine, and phenobarbital to induce coma, and she survived. And that's very uncommon. Currently, as I told you before, very few patients have survived to rabies, just 10 patients. So the Milwaukee Protocol is a combination of drugs that have saved the life of very, very few patients. This is not a proven antiviral therapy. However, because we know that the patient is going to die, we can do something to try to save the patient, okay? So the Milwaukee Protocol is a combination of drugs to try to save the lives of the patient. So we can use it with the patient. Most patients will die, most. But we know that some patients have survived, okay? And you can find this, you will study maybe in the internal medicine. But I remind you again, we don't have any proven antiviral therapy against rabies. So what about the prophylaxis? What about the prophylaxis? Okay, we have vaccines. These vaccines are used in humans for post-exposure prophylaxis, not for pre-exposure prophylaxis. When I teach this class every year about the vaccines, I classify the vaccines into two different groups. One group that I call the cheap vaccines, also the worst vaccines. And these vaccines, currently we have two types, the Semple rabies vaccine and the Fuensalida rabies vaccine. You don't have to remember the names, okay? Just remember that they are the worst vaccine. And why are they worse? Because they don't work very well, and because they have a lot of complications, okay? Many side effects. Why? Because of the procedure to make the vaccine. These vaccines are made in the brain tissue of animals. So we infect the brain of some animals with the rabies virus, and we take this tissue, this brain tissue, to make the vaccine. So we use the nerve tissue from the animal for vaccination. These vaccines have a lot of complications, a lot. If you are interested, you can read later in the complements for better understanding, I think. So these are the cheapest and worst vaccines. Currently, we also have another group of vaccines, the expensive, but also the better vaccines. These vaccines are not made in the brain of animals. These vaccines are made in cell cultures. They are more expensive, but they are safe and they are effective. So currently, there is a very strong international effort to remove, to eliminate the cheap vaccines, the nerve tissue vaccines, because they don't work very well. And they have a very high incidence of complications. So currently, we should remove these vaccines and use these vaccines, the better vaccines. 10 years ago, when I was in Hanoi, the vaccines that we were using were these vaccines. So some patients had complications. Currently, I don't know, but maybe, well, I think you have to ask your teacher of public health. Currently, I don't know which vaccines are available in Vietnam. I don't know. So look, what about post-exposure prophylaxis? Post-exposure prophylaxis is the only hope for patients with rabies, the only hope to save their lives. So, if a dog bites you on the street, you have to go immediately to the hospital to receive post-exposure prophylaxis. Post-exposure prophylaxis should be given as soon as possible after exposure. We should give post-exposure prophylaxis before viruses enter in the local peripheral nerve, because if not, the patient may suffer rabies and they will die. So how can we do post-exposure prophylaxis? Post-exposure prophylaxis, I explain you here. Post-exposure, so after exposure, prophylaxis against rabies is made by, firstly, with the vaccine, by vaccination. So the vaccine is given for post-exposure prophylaxis, for you to produce antibodies. We give this vaccine 4 times. At the time of infection, 3 days later, 7 days later, and 14 days later, 4 times. If you are immunocompromised, you need another dose later. I am sure that some of you already know about this. Last year, when I was teaching to one student received the prophylaxis against rabies. 4 doses of the vaccine, okay? So a lot. So post-exposure prophylaxis, firstly, because of the, firstly, with the vaccine. But at the same time, we have to give you a specific immunoglobulins, a specific antibodies. And these antibodies, these immunoglobulins, are injected around the wound. The purpose of this is to block, to inhibit, to neutralization of the rabies virus before the virus enters in the nerves. So post-exposure prophylaxis is vaccination, but also immunoglobulins. So the purpose of vaccination is that you produce your own antibodies by yourself 5-7 days later, okay? This is post-exposure prophylaxis, and you must remember this perfectly, because this is very important and this is very common in Vietnam. You are going to do it many times. But not only that, cleaning the wound is very important. A proper cleaning of the wound may reduce the risk of rabies a lot. How? With water and soap, with quaternary ammonium compounds that we studied in the practice, with iodine. Proper wound care is also very important. So what about pre-exposure prophylaxis? What about pre-exposure prophylaxis? This is not good for humans. We have vaccines, yes, but this vaccine is only given for some people, for people with a very high risk, for veterinarians, for laboratory workers, and people who handle animals. Not for all the people, only for some people, not for all the people. Pre-exposure prophylaxis is important for animals. So currently, the management of animal rabies is the key, is the most important way to prevent human disease in the population. However, very few countries have eliminated rabies, very, very few. How can we do it? Vaccination of pets, vaccination of cats and dogs. This is required by law. Also in Vietnam, this is compulsory in Vietnam. However, not all the people do it. Very few people do it. If you have a dog, please vaccinate your dog against rabies every year. And why is this vaccine not useful for people? Well, it's useful, but not very good. Why? Pre-exposure prophylaxis in humans, vaccination of humans is not recommended, only for some people, because we need 3 or 4 doses. Because we have to repeat the vaccine every 2 to 3 years. We have to check if we produce antibodies against the vaccine. And even if you are vaccinated, you also need post-exposure prophylaxis. If you are vaccinated against rabies, you also need post-exposure prophylaxis. So what's the difference? The difference is, if you are vaccinated, you don't need immunoglobulin. You only need the vaccine. That's the only difference. So these are the reasons why pre-exposure prophylaxis is not indicated in humans, only in people with a very high risk. And finally, to finish the class, this is not related with rabies, some notes about encephalitis in Vietnam, because encephalitis in Vietnam is a very serious problem. When I was 10 years ago in Ben Vinh Chorai, in Hoa Ben Nhit Doi, yes. When I was there, every day we met 2 or 3 patients with encephalitis every day, and dengue, of course, dengue every day, dengue and encephalitis. The diagnosis of encephalitis is very difficult because all patients with encephalitis, whatever the virus, they show the same symptoms, and the diagnosis is very difficult. In Vietnam, viral encephalitis is associated with very high morbidity and mortality. Mostly herpes simplex virus type 1 encephalitis. This is the worst. The microbiological diagnosis is difficult because we need complex equipment. We need PCR available against many different viruses, and that's only possible in some hospitals. So currently, just 32% of cases with viral encephalitis have a final etiologic diagnosis. In Vietnam, the most common causes of encephalitis are Japanese encephalitis virus, maybe the first, dengue virus, because dengue virus also causes encephalitis. Remember the picture that I showed you yesterday with dengue in the center, encephalitis. You remember?
Yes, the 3 circle.
Yes, exactly. Herpes simplex virus and enteroviruses. For example, polioviruses, okay? They are the leading causes of encephalitis in Vietnam. So currently, we need strong efforts to vaccinate people against some viruses, against the most important. Japanese encephalitis is the most important. So currently we know that most young people in Vietnam are already vaccinated against Japanese encephalitis virus. If you want to read more information about encephalitis in Vietnam, you have here this paper that was written 6 years ago. This paper is free, and this is written by Vietnamese people, and you will learn a lot of encephalitis in Vietnam if you are interested. Okay, do you have any question about rabies? Oi, do you want to say something about rabies? Oi. Questions?
Các bạn có câu hỏi gì về virus dại không ạ? I think that's maybe no.
Okay, so I remind you to answer the questions, the test questions, before Sunday for lesson 15, 16, and 17. Okay? Don't forget. So if we don't have any question, no question.
No.
No.
So we finish? Okay, so we finish the meeting and we will meet again for the last class next Monday. Okay? Okay, so goodbye and good luck.
Goodbye.